Well, good evening. I'm Kay Carradine. I'm president of the League of Women Voters of Coos County. We're delighted you could join us this evening. The League of Women Voters is a nonpartisan political organization encouraging the informed and active participation of citizens in government. It influences public policy through education and advocacy. The League is active locally, at a state level, and nationally. Our speakers tonight will be Brian Moore, President and CEO of Bay Area Hospital, and Troy Cribbins, who's their board chairman. And the format for this evening is very straightforward, but if you've been to League events before, you know it's also very structured. Brian and Troy will give a presentation of their materials for about 30 minutes, and then take audience questions for about 50 minutes. All questions must be in writing and given to our members who are placed right back there. And if you have they have to be written. If you think of another question that you wanted to write down and you didn't, just raise your hand and one of them will find you and deliver it sometime here. We call these people screeners. They're not here to deny questions, but what often happens is we'll have multiple questions that are the same question. So their job is to sort of pull that all together and combine my questions. And I will be your moderator this evening, so the questions will be delivered to me. And I might also combine some questions because we do want to maximize the number of opportunities for people to have questions here. So we're asking the presenters to be succinct in their answers. On the other hand, of course, people want very thorough answers, so that should all work. We do have voter registration forms available out at the table too. If any of you have moved, need to re-register before the 30th of April for the May election, we have the forms out there. So you can see Susan Henderson or whoever is at the table. So with that, I will turn it over to Troy. You're going to start, right?
That's correct. And that's working great. So thank you, Kay. Appreciate that. And I'm going to stand up if that's okay. I don't have any, I'm just talking. Brian's the smart one with all the facts and figures. I'm going to start, for those of you that have heard this already, I'm going to apologize. It's pretty repetitive, but essentially the story hasn't changed. I'm going to kind of talk about how this started, why we're going where we're going, and how what our plan is moving forward. So that brings me clear back to the beginning of the pandemic. And at that time, before the pandemic, the hospital was looking for a new electronic medical records system. The one we currently had was timed out. There were no more updates. So it wasn't a matter of we should hang on to this for a little bit longer. It was we have to replace this. We can't keep moving forward. At that time, and still, Epic was the gold standard for that. And we wanted to move that direction. We also wanted to help some of our partner facilities, North Bay Medical Center and Bay Clinic, and we sponsored them in getting Epic in so that we could communicate as a healthcare community much more efficiently. Well, Epic is fairly expensive. I think we had a total of close to $40 million, right? 30 for us, and then it was 10 and 5 to the other, 10 million to North Bay Medical Center and 5 million to Bay Clinic to help them get started. No sooner did we pull the trigger on do that we were hit by the pandemic. And then the pandemic affected so many service lines throughout the hospital. We were no longer able to do outpatients. And so if I break some of this down into revenue generating things, I don't mean that callously. I realize that our purpose there is to care for our community. But there are some facts that if the hospital is not able to generate a margin, then it can't be there. It can't help anyone. And part of where we were able to make things go was by having these revenue-generating service lines that help cover the costs of what we would lose on the poor reimbursement from our Medicare and Medicaid population. In that end, as a community, we are 85% Medicare covered community. Our commercial payer mix is about 13%. The hospital needs 23% just to break even. So we're already struggling with our market share, our community, with making the hospital profitable just straight off taking care of people that come in the door. With the pandemic, that amplified that cost loss tenfold. The only people that were coming into the hospital were individuals that were ill, and the hospital was losing money on every one of them. Medicare essentially pays pretty close to 30 cents on the dollar. And in our current area, our Medicaid reimbursement is closer to 19 cents on the dollar. And then our commercial payers are closer to 30 to 40%. Is that correct? 65%. So we started, the hospital was hemorrhaging money. I know at that time, as a board, we had discussions about, hey, we need to tighten our belt and we need to be careful. But we also said at that time, we're not a factory. We don't make widgets. We take care of our community. We can't just shut down these services. The pandemic will be over soon. Things should slowly turn back to normal, and we can weather through this. We had pretty good savings and investments, and we were using those to help us get through that. When the pandemic was over, things did not get better. Things did not go back to the way they were. We had trouble getting our orthopedics back. We had trouble with maintaining our cardiology programs. All of those other service lines that were helpful to help the hospital continue to be able to provide those services that they lose money on were not returning to the same extent. There's been claims of mismanagement out there, and that's how we got here. That is very far from the truth. In fact, if it wasn't for Brian and his team, who were able to garner a $60 million turnaround at the end of the pandemic, the hospital would probably be closed already. They did a fantastic job of trying to find every place they could turn around. We consulted many consultants, hospital experts, to help us guide us through that and to check ourselves, to say, are we doing the right thing? Are we missing something? Are we, in fact, mismanaging this? We were instructed over and over again, no, this is what's going on. This is the market. Also during that time period, I'm going to kind of jump back a little bit to Epic, because it was a tough rollout. And if you were there at the hospital and you were a nurse or a provider, it was difficult. It did not go smoothly. Part of that issue was when we first decided to do Epic, we were assigned a partner, kind of a mentor, a setup partner, which was OHSU. At the last minute, they were not able to do it. I think they were struggling again with their situation in the pandemic, and we ended up having to work with St. Charles Medical Center. And St. Charles Medical Center is a great facility, but they were not large enough or had the capacity to handle the integration of Epic for us. And they were struggling on their own, managing their Epic crisis and their patient care system. They didn't have as much bandwidth as we would have liked or frankly needed to make that transition much smoother. And we continue to work on it to this day. I think it is much better, but I do realize that there are still working issues with that system that we still need to get the kinks out. So that's all kind of underlying that as well. Then, over the next 2 years after that, we have experienced approximately 25% increase in salary costs during that same time period. Also which, during that same time period, we maybe got a 1 to 2% increase on our reimbursement. You don't have to be a business major to realize that our costs were shooting up like this, and our reimbursement rates were trending pretty flat, and they were not going to make up. That is not just an issue with the hospital. That is an issue with healthcare in general. And it is not just in our county, but it is in our state and it is across the country. Small, rural, independent hospitals are having a greater and greater time difficult time making ends meet because of the increase in costs and the poor reimbursement from both Medicare and Medicaid. For 2 years, the board and the executive team have been struggling and working on how do we move forward? How do we ensure that the hospital is here for another 50 years in its same capacity, and not just in its same capacity, but in a position to be able to grow and expand services? And of all the things we tried and we talked about, it kept narrowing down that you should merge with a larger system who has the ability to disperse those costs across a much larger population and much more volume, much more revenue. Industry trends are saying that a healthcare organization needs to be around $750 million to $1 billion net revenue to weather the next, for the next 5 to 10 years to be able to cover their costs. We are a $250 million organization. And we are geographically isolated. I know everyone is here because they want to be here, and we love this community. But it comes with some negative side effects. Some of those are we're isolated. Another one is that we are the 32nd out of 36 poorest county in the state. We have those challenges. If we had, and my point being is that it is possible for small, rural, independent hospitals to be successful. But they have to have, there were 2 commonalities for that to be true. One of them is they had to have high volumes and a high commercial market share in order to cover their costs and allow them to keep doing it. We have neither of those. Another one was they had to have a strong permanent tax base. We don't have that either. I can go through that. In the early 90s, 1997, the hospital was doing well. Costs were not as up. We had a better market share. We had specialty procedures that were helping us cover those costs, and we had good financial backings. We decided not to take our tax base. We realized that our community was struggling, and if we could continue to manage our hospital without that tax base, then that would help the community. That was a conscious decision. Unfortunately for us, not long after that, the Oregon State Constitution changed, and we were not able to reinstitute that tax. So even if we wanted to, we couldn't say we're going to reinstitute our tax to help support the hospital district. One of the things that we tried to do is we said, well, what about floating a bond? Why don't we float a bond out there? We can get the money we need to help support the hospital. We did some polling, we did some research. The polling came back, it wasn't, super strong. And if you're from this area, you realize that there is a history of those types of bonds not passing. We have the public safety levy that just failed. We had the library bond that failed. Just most recently, the URA at North Bend School District got turned down. All of those things, whether that's right or wrong, is for another conversation. But the point is the community feels overtaxed already. And I've already indicated that most of our population is over 65 and retired. So I feel like they're fairly stressed on how much they can contribute, how much more they can contribute. So we did not think that it was worth that risk to get the bond. Put all our eggs in that basket. Secondarily, talking to the tax assessor, we were only going to get about $4 million a year, which even that was going to be affected by compression, because we have overlaying districts. And you're only, I think the cap is $12 a thousand. I could be wrong, but it's similar to that. So once you reach that, then they start taking money from those other districts to keep it at the $12 a thousand. So we essentially, we were only going to get around $3 million, and our surrounding or overlapping districts were going to be affected negatively as well. It's not a win-win for everyone, and that $3 million a year is not going to be enough to keep our hospital going. I think last month we lost $1 million, but we're trending towards $24 to $30 million a year loss. $3 million isn't going to fix that. We had several meetings with community partners where a local consortium was discussed. I believe we have to work with our community partners. We're the medical center, the clinic, our outlying critical access hospitals, Those are all important partners. We can't live without them, and they can't live without us. The idea, though, of us forming one centralized system with all these organizations was wrought with problems, and still at the end of it did not solve our problems. If we put, at a maximum, if we talked about Lower Umpqua Hospital, Coquille Valley Hospital, Southern Coos Hospital, North Bend Medical Center, Bay Clinic, us, and Advanced Health, that's 7 organizations. If I assume many things, which are huge assumptions, one is how we form them all together under one operating system. Because as it is, there's 2 private systems in there, there's 3 critical access federal systems, there's our government system, and Advanced Health, which is not an insurance company, but essentially that's their mission, is to provide and distribute the Medicaid dollars to our community. That's not going to happen in 3 months. That's going to take years. We engaged an M&A special attorney who said, it's possible, but that's probably 2 years in the making. So let's assume that did work. Now we're all together in one organization. We're still only $500 million. We still haven't changed our risk pool. We're still dealing with the same patients, the same market share for insurance, the same high-level Medicare, Medicaid patients. Part of the benefit of being part of a system is they have processes involved already. They have cost-saving methods already in play. If we made this system, we would have to develop all of those. And that, again, takes more time and takes more money. Also, at least half of those organizations are struggling financially as well. So we would really just be cobbling together a bunch of community group organizations, which are full of bright and talented people, but it doesn't change the market. It doesn't change the state of healthcare as it is now. We're still going to be receiving poor reimbursement rates. We're still going to be minimally commercial payer insurance. All of those things don't change. So we're really just kind of bigger and struggling in our area. At some point, it's okay, even if you have lots of talented, committed people in your community, to reach outside of your community and ask for help. Other people have great ideas, and there are methods and systems that do work. So we looked at a tax farm. It didn't work. We looked at forming a local consortium. That didn't work. We currently are still working with legislature to help us bridge fund so that we don't have to cut any services while we're working on affiliation or partnership with a large health system. The system we chose. So when we decided the formula, when we got to where we were like, listen, long term, to keep Area Hospital here and vital at this size and the capacity to grow and add services, we need to merge with a larger health system. We sent out 18, give me my, thank you, RFPs. We got back 8. We dropped down to 4. We ended up with 2 that we did what they call due diligence visits. They came to us, examined our facilities, and then we went to them and examined them. The teams that went were the board members, executive team, and several physicians. And they did likewise for us. In the last minute, I can say it now, one of the partners was Peace Health. At the 11th hour, they dropped out. They indicated they were interested in us and being a partner with us as we sort of fit their model. We were all up and down the Pacific Northwest on the coast. But they had just purchased 2 large private physician clinics and did not have the bandwidth to do both. So they stepped out. Quorum Health was still at the table. We continue to work with them. They have continued to address what our hospital, our board, and our concern for our hospital were. They have been at the plate the entire time. Now, we were supposed to sign an official agreement at the end of March 31st. We were not able to. And I am excited to share some news with you tonight as to why we were not able to, and something that we have been wanting to tell you but have not been able to share with you. There's been lots of concern in the community that Quorum Health, which is a healthcare management company, they own McKinsey Willamette, and 12 other hospitals, mostly kind of in the, west, southwest part of the country. Their offices are in Nashville, Tennessee. If you Google them, it's not going to look good. They have, they're financially backed by private equity. But there's a backstory to that. Quorum Health was founded from a spin-off from CHI, which is a really large health system. And when they were initiated, they essentially were given 18 hospitals. They were all underperforming hospitals. It was the one CHI were wanting to get rid of. Thank you, CHS. CHI is another large system. Yeah. They went into receivership with those 18 hospitals. They restructured them. They moved many of them to different systems that fit better to them. They may have sold several off, and when they were left, I think they were down to 6. My numbers could be off a little bit. With that, they were able to restructure, gain good financial ground, start to grow their bottom line, and they got to a place where they said, we are interested in running rural hospitals. We have processes. We're ready to expand. And that's how we got involved with them. What I want to tell you, that I get to share you, is while there's some concern because they're private equity or for-profit and we're a nonprofit government hospital, is we are working on maintaining Bay Area Hospital as its nonprofit status. We've been working on it for months. We haven't been able to tell you because that's their private information. If you have questions, I can't answer them right now because I can't tell you how we're going to get to that or how that's going to work. But that is the end goal, is that Bay Area Hospital maintains its nonprofit status. I think I've hammered it. Am I missing anything? Yes. So today, I think we'll have to wait. We'll do questions at the end. That's really, I just wanted to share with you where we started, things we did to get here, decision processes we made to go along that route, and where we're at now. So the good news is we are still working on a deal with Quorum Health. We hope to have that finished in maybe 3, possibly 6 months. It depends on their processes and structures to get us to maintain our nonprofit status. We continue to work with them doing due diligence. They're doing due diligence on our side, and we will continue to effort this. Our focus right now is working with the legislature to help us with bridge funding or sources of financing so that while we're waiting for this to happen, we don't have to experience significant cuts because the losses keep coming. And this is not anything we're making up. This story is the same. If you've heard the story, I haven't changed it one bit. This is the market. It is a rough market to be in healthcare right now. On a bigger, whole different conversation, something needs to be done about how our healthcare system is run. Right now, though, the board's job and goal is to make sure that Bay Area Hospital, however the game is set up, stays here, stays vital, and provides care to our community at the capacity we're doing now. It's been said to us that profitably we could restructure and drop down to a type B hospital or a critical access hospital ourselves and be financially stable. That's probably true. I personally don't want to see that. I want to see us as the place that our community gets to go for their health care, for orthopedic surgery, for cardiac care, for oncology, to have a baby, all of those things. And, in fact, point in case, we had a mass casualty event occur Monday. We had the airplane that slid off the runway. Fortunately, there was no major injuries, but our team at the hospital, the ER department, worked like a well-oiled machine. They brought those people in there, they administered care, and the other patients that were in there already indicated they didn't even notice this was happening. That is due to your hospital team. That is due to your management. That is due to the leaders, and that is due to the staff that provide you care every day. They perform that. That has to stay here, right? That's my opinion. That has to maintain that. So we will continue to work with the legislature or whomever we need to help us maintain our hospital and the status it's in. And not just the status in, but look at potential growth. We would like to see growth. Thank you. Appreciate you listening to me.
Troy, well done. Thank you. I'm going to try to keep us to that 30 minutes. So I'm going to go through my sort of detailed information quickly, but I will be happy during the Q&A period to come back and expound on anything that is of interest. For those of you less familiar, we really do serve a region from the California state line up to Florence. That's about 3-hour drive along Highway 101. And we draw patients from that entire region. We offer some very unique services fitting into that fabric that makes up the healthcare system here on the coast. And Bay Area Hospital in that region's the only place to have a baby in the hospital. It's the only cancer center that's available, radiation oncology, medical oncology. It's the only place to have a heart attack treated in a cath lab. And as Troy was just highlighting, it's the only level 3 trauma center. We had all 5 of those patients show up simultaneously, and we had 4 general surgeons, trauma surgeons, and our emergency department team instantly on site. Now, it was just some strategic timing because it happened to be when the hospital physicians were making their rounds. It was also shift change, so that was a good time to schedule a major event. I'll have you know, though, as we partner with local fire and EMS and the airport, this was almost the exact scenario that we drilled in this community just a few months ago, which makes me a little bit worried about what scenario are we going to pick next if it has any kind of predictive value. We're also the only place for many specialty surgical procedures. We've got a Da Vinci robot offering minimally invasive approach, really state-of-the-art right here on the coast. And we also offer the only inpatient behavioral healthcare unit. You know, resilience comes to mind. We have been testing our resilience. This is our profit margin, our EBITDA over the last few years from 2013 to the budget of 25. You can see that deep ravine that we found ourselves in the middle of the pandemic and our steep climb out. That light gray or blue bar on the end shows our actual performance this fiscal year compared to the more positive budget. We really saw an unanticipated slowdown in our revenue cycle improvement and a more rapid increase in expenses. So these are the slides I'm going to start to run through quickly so we can get focused on your questions. But, you know, when trying to answer this question of Bay Area Hospital's been serving this community for 50 years and it's just worked, what's going on now? What's different? Most of our revenue still flows in a fee-for-service, meaning when we see a patient and we get to provide care, we send a bill for that service and we have the opportunity to get paid, to keep those healthcare dollars in our local healthcare system. So when we found ourselves in that deep hole, one of the first things we were focused on was growth. And that hits twofold for us. It's really over the key part of my graph there. Because our mission is to improve the health of this community every day. We do that best when somebody knocks on our door with a healthcare need and we have room to say yes. And so growing volume not only helps us with our mission, it also helps us with our revenue. And so you can see the steep growth here, really from the last 2 years. And we're now treating more patients than the hospital's ever treated before on the inpatient side. This snapshot is the last 12 years. But we have grown past whatever was driving volume in 2017. Emergency department visits also near at record levels. Operating room cases, they're down a little bit. Orthopedics and our eye cases, the eyes, about 800 of them moved out to an outpatient center. The 15-minute cataract surgery, in most communities, those moved to an outpatient center years ago, and that's probably a more appropriate space for them. And then that lower graph is our cardiac cath lab, and you can see some bumps of rapid growth, but really an ongoing baseline growth continues. So the hospital is living its mission. It's providing care to lots of people. Ooh, I lost my ability to advance the slides. It's going to come back though. Let's see, page down. Thanks for your help. All right, so now we'll look at how we're doing with our productivity. We actually added a number of employees as volume grew, and that was really focused on our team that was involved in providing patient care. And it's not just the nurses and the clinical staff, it's also the support people who are involved. But we went back and looked at our productivity. So here we're looking at full-time equivalent employees. And we got a fancy healthcare term here, case mix index adjusted patient day. What does that mean? It basically allows us to take our inpatient volume and our outpatient volume and adjust it for how sick those patients are and come up with one number. So it looks at the hospital's volume and takes into account kind of the acuity. Well, 12 years ago, at the beginning of this, we were using between 5.5 and 6.5 employees for every patient day. And you can see that downward trend and a little bit lower here as we get into 2024. And we're now at 3.5 employees for every patient day. So we're being a lot more productive and efficient with our staffing. Well, how about our supply cost? Between labor and supply costs at a hospital, represents about 80% of our cost, 70 to 80% of our cost. And so here again, we're looking at it relative to volume. And you can see that nice downward trend over the last few years, down almost to 6%. And we're right in line with the hospital's best performance in this time shot of looking over the last 12 to 14 years here. In terms of managing our supply expense. So if we're busy and we're managing our labor well and we're managing our supply expenses, what's happened? Well, there are definitely some things that Troy talked about that have changed in our environment. We'll talk here about the commercial payer mix. Back in 2009, we had almost 22% commercial payer mix. And now we find ourselves with only 13%. And so looking at recent data, within the state of Oregon, Bay Area Hospital had the highest dependence on government payers of any DRG hospital. That's a payment methodology that really focuses on the larger hospitals. Critical access hospitals and smaller hospitals have a different payment methodology through the government payers. So one of the things is we get paid like the big city hospitals, but we really have a lot of those same challenges of the smaller rural hospitals, and it puts us in a little bit of a pinch point. And so this downward graph that you see here is what percentage of charges does the hospital actually see in terms of cash payments? And again, going back a few years ago, we were sitting here at 46 to maybe 48%, and we're now sitting down here around 34%. So if we charge $100, we used to see $46 to $48, and now that's really going to turn into only about $34 in actual payment to the hospital. We've got to compete for those fantastic caregivers who take care of you, and we're really finding ourselves competing more and more on a national scale. Healthcare workers are in short supply. My entire career, we've been talking about the coming shortage of healthcare workers. Well, we're really seeing it today. And you can see from 2012, our average hourly rate grew from $34 and now sits at close to $50 an hour as our average hourly rate. We've also seen a significant increase in what the hospital pays for physician staffing. Now, most of our medical staff are independent. They run their own finances. They're not employed by the hospital. They're not paid by the hospital. But there are some specialties where we really need to employ them so that we have coverage. And what we've seen is not only have the cost increased for each shift that we need to provide coverage, but as we have seen physicians leave the community and not be replaced, the hospital has responded to requests from our independent physician partners, and we've had to contract directly with physicians to fill in the gaps. And that's increased our costs by $5.2 million just in the last 4 years, and that's $5.2 million a year. All right, I tried to keep it brief, and we are happy to take your questions now. Thank you.
I apologize. I thought I talked for 10 minutes. It turned out it was 28.
It's all right. It was good. To bring us a bigger set of questions. Okay.
Okay, well, we'll just start with some simple ones. If I think you've covered it, I'll probably put those to the end. But anyway, this question is the Cancer Center a separate entity, or is it a part of BAH's future, or current and future?
Yeah, so Bay Area Cancer Center, created part of Bay Area Hospital. For many years, the structure was a little bit of a hybrid.
Use the mic so it's off, right?
I think this will probably help the recording as well. So Bay Area Cancer Center is integrated. For many years, it was a set of contracts where some of the employees were employed by North Bend Medical Center, and through a contractual relationship, we worked to provide cancer center services. And a couple of years ago, we really simplified that structure, and those are all Bay Area Hospital employees at the cancer center. And it's integral to our future going forward.
Okay.
Just to tap onto the end of that, and yes, it is an integral part of our future. And to me, that is one of the exciting things about partnering with a large health system that allows us the capital resources to grow those specialties like oncology. I was part of a study in our area like 2 years ago. Essentially, the crux of it was we have higher than normal cancer rates. And I think that's part of what I said earlier, where we're lower on the economic scale and we're much higher on the age scale. Having an oncology center in our community, to me, is critical. In my day life, I run a home health and hospice agency. I see the difficulty our patients have in accessing health care every day. The thought of someone struggling with cancer who doesn't have a lot of means, having to go to Eugene or Medford or Portland for that care, doesn't make sense to me. We have a good community, a strong community, bright people. We need to figure out how to keep that here. And to me, partnering with a large health system that has the resources, can help us with recruiting, and has the capital that we can add to that to keep those services in our community.
I know you said, Troy, that you couldn't talk about the not-for-profit status in detail, but this is actually a pretty good question that you may have part of the answer. Explain whether the for-profit hospital will still be providing community benefits such as charity care, support for the Kids Hope Center, and community grants. As a for-profit hospital, are there differences to charity care requirements for patients who don't have insurance and resources?
Certainly. Even if they had maintained their for-profit service, they had agreed to maintain our charity care policy. That being said, if we maintain our nonprofit status, then yes, that makes it easier for us to keep our commitment to our community for charity care and the Kids Hope Center alive and well. Did that answer the question? I tried being brief, but I'm not very good at it.
Good. Here's one for you. It says it's for you. How much is written off after commercial insurance pays when patients are unable to pay?
I appreciate that being to me, but I am going to segue that right over to Brian because I don't have those numbers.
I'm sorry, I'm not sure probably exactly what you're asking for. When we get into the commercial insurance space, then what is commercial insurance? If you get insurance through your employer, that's a great example of commercial insurance. And so, it comes in a variety of flavors, but many times there's a copay, or if you're in a high deductible plan, you might be fully accountable for the contracted rate up until the point where you reach your deductible. And so what we do is we work with patients if they need a payment plan, if they happen to be on a deductible plan and maybe they need some more time to pay that. And then we will make a contractual allowance based on the contract, and we'll write that off as a contractual allowance. And then we'll receive payment from the copay from the patient, and then the rest of the payment from the insurance company. So I hope that answers the question. If you need to catch me after for more detail, I'm happy to answer that.
I was going to try to, maybe what they're meaning is, I think we indicated commercial payers pay us about 60 cents on the, does that 40 cents get just written off?
Yes, that'd be the contractual.
So that's the contractual allowance. So for every dollar we charge, if the commercial payer gives us 60 cents on that, that other 40 cents gets written off. And that's the same when we talked about the government payers. For every dollar we charge, we get 30 cents. It means we're writing off 70 cents and 80 cents on Medicaid.
Brian, can you explain how the merger contract will address the tension between shareholder profit as a priority and patient care? And who will decide where profit is spent?
We did a number of things in structuring that agreement with Quorum to try to make sure we had alignment. The board set out I think about 7 or 8 objectives, and really wanted to find a partner who would commit to taking good care of our employees, commit to keeping care local, commit to not only keep care local, but to make expansions in local care, and to make sure that there was a strong local voice that continued in the governance of the hospital. And so, Quorum has committed to employ our employees at similar title, the same rate of pay, give them years of service credit. They're proposing a local board that would be up to 9 members. 3 to 5 of those positions would be reserved for members of Bay Area Hospital's medical staff. The CEO of the hospital would serve on the board, and then the rest of the board would be made up by residents of the community here. So that's a strong local voice. That's not a full fiduciary board, but Quorum gave enhanced powers to that board during the 10-year period where they committed to keep core services here in the community. And it would be this local board that would make any decision to change the makeup of local services. The board would also be responsible for appointing medical staff and have a really significant voice in the strategic plan of the hospital going forward. Quorum also committed to significant capital investment over the first 10 years to commit at least $75 million. We have outdated equipment that needs to be replaced, but I can tell you that $75 million would require not just replacing equipment, but also investing in new services. And so we think all of those things fit together with a very coherent picture about a partner who has long-term interests, who wants to see care here with a voice that is shaped by a voice, an ongoing voice of us who live in the community.
I'm going to read this question because it's not exactly the one that I had just asked you, but it's a similar, and I want whoever wrote it to know that you just answered it. How will the health district be restructured under the quorum arrangement, and any additional information related to the type of contract, structure of quorum arrangement, and ability for the public to participate in future operations? Another question we had that is similar has to do with the separation of the district versus the hospital. Troy, you might want to take that.
Certainly. And some of that, and I'm going to apologize, but some of that is part of the things that we don't know. That's going to be with them working to keep us as a nonprofit. There will be some changes in how that structure is set up. Some of that, I don't know what that's going to look like or how they're going to do that. And some of it, I'm not allowed to say. Sorry. I can't help myself. So what I can say is I know private equity has a bad rap, and I do know there are players out there who take advantage of things. I can't guarantee what tomorrow's going to bring. What I can tell you is that everything that I've seen them say, they've walked it. Everything that I've seen them do, they've backed it up. And for an example of how they run a rural hospital, I'd look to McKinsey Willamette. I just noticed today, and I'm going to get some of these wrong, but they just received like 4 or 5 awards. There was a Women's Choice Award. They've got a Cardiac Heart Surgery Award. They're a 4-star hospital now. They invested, I think, I don't know what their tower cost, but $70 million in building that new tower for them. And when patients go there, they see McKinsey Willamette. It doesn't say Quorum Health. It says McKinsey Willamette. Their board is made up of their local community. Their physicians are from their local community. Their nurses and other people that work at the hospital are all from that community. And when they go into that service, when you go into McKinsey Willamette for care, you just go in and you get your care from people that live next door to you. That's what I've seen them operate as a partner. That's what I'm expecting, and that's what our board has asked for in that partnership with them here.
This has to do with employees. What happens to the retirement plans for employees who are already retired? Will they continue to receive benefits? What about the employees who have been vested and or expect to retire under the hospital's plan?
So we have employees who have retired probably on a couple of different plans. And there was a shift from defined benefit, the classic pension plan, to the defined contribution, the 401k plan, where we've got more involvement as employees and kind of preparing for and managing our retirement nest egg. And I think probably the bigger piece to answer with this question would be those employees that are on the hospital's pension plan, the defined benefit. And I can tell you from an outset, that's been one of our top concerns from board and management, is to make sure that those individuals who served this community and are now retired do not see an interruption or disruption to their pension benefits. And so we have worked with the actuaries as we have put together our budget and the proposed transaction with Quorum. And I can tell you there are funds available to meet the hospital's obligation for the pension plan so that those retirees see no disruption in their pension benefit.
How close are we to being fully funded? 90%.
97%.
So it's pretty close to 97% fully funded currently. We are working on several different strategies. One is finding a lump sum of cash to just fill it, annuitize it, and put it aside, or other ways where we continue to add to it to keep it fully funded. The point is that will be there and it will be funded, and you will receive your retirement benefits if you're getting those.
This is also just a slightly different way of asking this, but if Quorum takes over the hospital with a different tax exemption, what happens to the Kids Hope Center that has to operate under a 501c3?
That was another commitment that really gets simplified with today's news of, this joint exploration of really finding a way for Bay Area Hospital to maintain its not-for-profit status. We had engaged our legal team. We've got some specialized attorneys that are helping us, and we had begun looking at some other scenarios. We understand how important that is, and we're committed to finding a way. And the good news is the pathway forward for the hospital really makes that easy to solve for Kids Hope Center as well.
I think that's been answered. If a patient in the emergency room needs to be transferred for a higher level of care, will there be a default transfer to Mackenzie Willamette, or will the patient or doctor have discretion for transfer to another hospital instead?
Patients always have a choice. And what I have seen in my career is that systems also have the unique opportunity to build clinical pathways. And what we can find often is that earns the choice, both from the physician making a recommendation to the patient and from the patient. And so we think that opportunity would be there. The parallel question that has come up and really been answered directly by some of the senior leaders from Quorum as our medical staff had this question, and that was, what's their plan for Bay Area Hospital? Is it going to be a feeder hospital, or is it going to be a sister hospital? And their immediate response was, it's going to be a sister hospital. They see it very much providing very similar services and continuing to do that into the future. That being said, today, the open heart surgery program earns a lot of referrals from our physicians and from our community at Mackenzie Willamette Medical Center. They have a really strong cardiology program there, and we're really excited to think about how we could build even more comprehensive clinical pathways that would provide for patients and physicians really an integrated and even more seamless experience. So that's how I would answer that question.
Can I tag on to that? I mean, currently we have partnerships and we work with Asante, Mackenzie Willamette, Riverbend, OHSU. Those decisions are still going to be made by the patients, by the physicians doing them. None of those people are changing in this equation. Those decisions will still be the patients, their providers, and they will go where their care is going to be best served.
What are the key services that must be maintained for a level 3 hospital? And is that the current status of the hospital? And will those key services be maintained for 10 years?
There's a couple of key services that are required, and level 3 probably refers to our trauma center and our trauma programs. A level 2 would be the next step up, and then level 1 would be the highest level. We have a couple of level 1 centers in Portland. Our closest level 2 center would be Riverbend. So we keep a lot of kind of single system traumas. If you start having major traumatic damage to multiple systems in your body, that's one of the things that is going to get you transferred. We're required to have A couple of things. We have a trauma surgeon who's on call 24/7, and that means we could get you to the operating room. In order to do that, we've got an operating room available and a team and anesthesia so that we could provide surgical intervention. Level 3 also requires an orthopedic surgeon to be available 24/7 via call. And just for comparison, when you get to level 2, now these surgeons need to be in-house to facilitate even stronger response. And then at level 2, you're also looking at neurosurgery typically being involved as well. So those are core services that we have in our level 3 with the general surgeon, the ability to get to an operating room and orthopedic surgery. We actually have some changing regulations that require a new medical director role and a few other things that are going to add cost to our program. And so we'll be having some conversations about how we can adapt and incorporate those new level 3 requirements into our program going forward.
What happened that made the entire orthopedic unit leave and move to Coquille, taking with it a very profitable enterprise?
That exceeds the time limits that we have imposed upon us. What I can tell you, though, is years of outreach and collaboration leading up to that. Most recently, a couple of years ago, when we were hearing some of the financial challenges from the orthopedic surgical group, was a collaborative effort with North Bend Medical Center and Advanced Health to provide a solution to the physicians. One party, Advanced Health, was looking at real estate acquisition. We were looking at practice management and recruitment support coming from North Bend. The hospital's role was really to focus on enhancing our capabilities for outpatient orthopedic surgery. We retained a consultant and fast-tracked a same-day total joint replacement pathway. Ultimately, it's hard to get all those numbers to be agreed to. How much is your real estate worth? What does the market say that it's worth? And what's that next orthopedic surgeon? And so, unfortunately, we saw that collaborative effort kind of unravel before it got to a solution.
I will say also, sort of an aside, our orthopedic practice is struggling just like we are. There's 3 of them left. They're trying to recruit. They've been trying to recruit for years. They're having trouble bringing in new surgeons. And, I don't want to speak for them, but I could say, I think they're getting tired. I don't think they like to do call and to work all the time. And they haven't had the new orthopedic surgeons that there's not much of a succession plan. So it's made it difficult for them and kind of left them in a tough spot of trying to figure out how they were going to, move forward. And that's something our community struggles with across the board. And again, I think that's where a larger system with resources and processes might be able to help us recruit and retrain more specialists.
This is a financial question. Could terms of the loan from Bank of Montreal be renegotiated to prevent default, and have other financial institutions been approached to help?
Unfortunately, we've defaulted on this loan twice. We successfully restructured that loan and put it back in place in October of 2023. So can it be done? Absolutely. Our bank also lives in a very regulated field, and I don't think they relish the idea at all on calling this loan and closing the hospital. They have that contractual right at this point as we're in default. We have maintained very close communication, and we've earned a lot of trust through that open and direct communication. First, by putting together a financial recovery plan that we saw with that near $60 million turnaround earlier. And not only did we put the plan in place, but we were implementing against it. And then we had clear communication as we saw some financial troubles return. We have explored refinancing with other financial institutions. And unfortunately, our current financial situation really positions us where we don't have that ability where other banks are interested or able to come in. Troy spoke to some of the dramatic types of solutions that we've kind of talked about. Shrinking to critical access hospital, or what Oregon calls a type B, which is a separate designation. The truth is that the region needs Bay Area Hospital to be bigger than any of those financial support systems really allow for. Just admitting the patients through our emergency department, where we're seeing almost 30,000 a year, means we need more than 50 beds. And that's before you talk about the operating room and those additional procedures that require a hospital bed. Unfortunately, we've experienced during the height of COVID what happens when we have to close beds. It is disastrous. It is gridlock. It is phone calls to Idaho, Washington, California, begging and pleading for a hospital bed with a nurse to admit our patients. Oregon has one of the lowest rates of hospital beds per capita of states in the nation, and we just don't have the capacity even in the state to absorb even our smaller region and have continuous bed availability. We really need to exist at this larger size to serve this community.
Also, Brian, earlier on in the process, we did reach out to several of our local community banks, and they were very honest. They wanted to work with us. They reached out to us. They wanted to help. They essentially said, we don't have the capacity. That's a lot of money. $46 million is a lot of money. They even, a couple of them even said, well, maybe if we partner with another local bank, maybe we can do something.
We found one who was yes in that.
Right.
Yep, we found
Right.
one who was a yes.
Was for the partner one.
Right.
Right.
To put a partner.
Right. But they weren't able to get it together. It is
We walked away because the rate was going to be better when we refinanced. They were willing.
okay. So, all right, I'm wrong. That doesn't happen very often. Sorry.
What's Quorum's record with respect to the rural hospitals, which it is responsible for? Are they a comparable size? Are they bigger, smaller? And how long have they been around? I know you mentioned when they restructured. So what length of time have those hospitals been with Quorum in this new structure? So I guess that's another way of saying, how does that part of your due diligence work? What did you see?
Yeah, Mackenzie Williams has been part of them since 2016. Most of the other restructuring took place in 2022. There are a variety of sizes of hospital. Mackenzie Williams is probably their largest. We would be probably their second largest. And then after that, they actually own multiple critical access hospitals too. So if you search the internet, if you Google, which can be a really good thing, but it can also be a really negative thing. If you search that, you won't see necessarily good quality ratings on their critical access hospitals. Part of that is the way CMS structures how that happens. You have to have a certain amount of beds, you have to have a certain amount of volume for you to be able to reach their star ratings. I deal with this on a regular basis just in home health and hospice, trying to get that extra star rating. But unless you're in an urban situation where you have a huge, tremendous amount of volume, and those ratings are basically based on when a person discharges, they're sent a questionnaire, they fill that out, and they send it back in, and those are compiled. I think there's some other factors to it, but it's difficult for a critical access hospital to achieve the volumes and the numbers for them to show. But what I will say is if you look at their website on LinkedIn, they celebrate the things that are important to us. They celebrate their staffs, they celebrate patient care, and those are the things they acknowledge and work for. So across the board, McKinsey Willamette's probably the largest. We would be the second largest. And then many of the others after that are smaller. Did that answer that?
This is a totally off the wall question, but you indicated that their market plan is to grow their rural hospital, the number that they have. Do you have an opinion on what the current national financial situation will do to their marketing plans or their?
I know.
Just
I
asking.
wake up every day and it's something different. So, no, I mean, the truth is, being serious, I try not to get wrapped up in day-to-day stuff. So a little side analogy. I know the stock market's really nervous, but for me, I just try not to watch it. I just leave my money there. At some point, this will settle down and it will come back. The market dips 10% like every 2 years and does a bear market about every 6 years. While it's not fun and it's kind of scary to watch, some of those dips and restructuring are normal. It is troubling to me that CMS is looking for $800 billion in cuts over the next 10 years. I have no idea what that's going to look like. And that sort of speaks to my initial comment of we have a healthcare issue in this country, across the world, frankly. I don't know what the solution is to it. And so, yeah, there is trepidation, there is concern about how the future is going to roll out. But I can't focus on that. What I can focus on is what we have today and how we're going to keep it for as long and healthy as we can.
And has Quorum said whether it will honor your existing labor contracts?
It was actually late in the due diligence process where they even had a chance to get their eyes on the labor contracts. And we really haven't had a chance to revisit the subject with them. So they have said, current state, they're going to hire the employees at the current rate, similar salary, recognize years of service. The contract really talks about what does it look like going forward. What we do know is that Quorum works with unions. They have a hospital here in Oregon. They have a contract with the Oregon Nurses Association. And we think that our employees have said they want a union. Quorum has said they want our employees. So we're confident they're going to work that out.
And if the partnership with Quorum does not go through, what's plan B?
I think Brian and his team are continually working with consultants and hospital industry experts, trying to figure out other plans for us to move forward. But if I'm honest, if we don't partner with some larger system, I don't know that the future looks that good. I think if we are here without a partnership, we look drastically different than what we do today. For me, that's not an option.
And has the Bay Area Hospital had a business plan with a market analysis and where each unit has a business profitability plan and break-even plan, like imaging labs, surgery, all that?
We do go through a strategic planning process. We go through our annual budget planning process. What I can tell you is that over the last few years, that process has definitely been disrupted from its normal rhythm. I think the hospital appropriately focused on how do we avoid crisis care and make sure we don't, in this state, in this region, tip over to that point where our system is overloaded as we were really dealing with the high points of the pandemic. And then on the backside has been the focus on financial survival. And so that has disrupted kind of our normal longer range planning, and we look forward to returning that. I can tell you there was deep financial analysis in our financial recovery. The Cancer Center had a 9 or 10x bottom line performance improvement. I can tell you there are other programs that are still moving along their improvement trajectory where we've identified goals and key processes and volume targets that need to be met as we look to make sure that we can preserve as many services as possible.
Specifically, we have a strategic plan, but it has got dust on it because we have not had the capacity or the bandwidth to move forward with it. I think all of us on the board and the executive team would like nothing better than to pull that out and start moving forward with it.
Will there be more cuts to services before the partnership with Quorum begins? Or are you looking at across the board status as it is?
Well, that's one of the things that, frankly, we're still evaluating. But with the hospital's financial performance, we're still using cash. And so when we go into an extended waiting period, back to our earlier conversation, we had a time frame and a budget that allowed us to honor those obligations, including funding the pension. We want to make sure that the hospital stays in a position where even if there's a delay, that we've got the ability to fully fund all of our obligations. And so the delay may cause us to take a look at some additional operational changes. And we're going to try to preserve as much as we can. And of course, the preferred way to get there is through growth, through the revenue cycle improvement. And so those are some of the areas right now that are getting the most attention.
For what it's worth, I was on the phone with Senator Deb Patterson, who's the chair of the Health Committee, this morning. I just missed a call from Senate President Rob Wagner today, and I have a call to the governor. I'm also meeting with Federal Senator Merkley next week, talking to them about solutions. We could use some help. We could use something to tide us over. I don't want to see any cuts, but I think Brian's point is, yes, that's possible. There potentially may be cuts the longer this deal takes to get done. And if we're unable to have capital to generate revenue generating procedures, or then things may look different. But I do know we're working really hard every day to make sure none of that happens. But as I said before, I don't know. Nothing's in writing yet.
And this question actually says what happens after the 10-year commitment by Quorum. I'm assuming you came up with 10 years for a reason, from a manageable standpoint, but.
No, you're actually really onto something when you say that. So, the letter of intent contemplated several different structures, but the one that had been getting the most focus had been a long-term lease, 30-year lease with 2 10-year renewal options. And so we have just experienced how quickly the environment can change. It's really hard to have something fixed for 30 years, 40 years, 50 years, and have it be a match. You have to update your strategic plan on a regular basis. We have to update our budgets. And so the 10-year commitment was to try to find a balance between, let's make sure that somebody's really in it from a long-term perspective, but also not handcuff them so tightly that they don't have the room to respond to an environment that could change. The legislature, we're talking about that. This is a record year. I think they've introduced somewhere around 3,500 new bills. Any one of those could make today's strategy and our approach not only irrelevant or unsuccessful, but perhaps even outright illegal. And so that's why the 10-year balance point was struck.
And from a business standpoint, 10 years is a long time for an organization to guarantee what it is you have.
Will the existing special district board be responsible for ensuring compliance with the agreement? And if so, how will they do that?
Yeah, and again, that may look differently now based on the information I've shared with you. But the district board will still be Pat, and it will be more of a supervisory role. They won't have a lot of teeth with their um, compliance issuance, but they will be there to try to ensure that quorum is being the partner they said they would be. But honestly, their choice would be to ask for a right of first refusal to have the hospital back. And at which point, then we're kind of right back to where we started, trying to figure out a way we're going to fund that, find the capital for it, and move forward.
This is kind of a whole different flavor. How much money will leave Coos County as a management fee to quorum each year?
I don't know the answer to that. We do know what the capital commitment is to stay here in the county. We do know what it would take if Bay Area Hospital were to pursue an independent pathway. Healthy hospitals, from a financial standpoint, really want to have greater than 200 days cash on hand. Today, at our size, that would mean that our balance sheet would need to be repaired by about $100 million. So if you add that balance sheet repair plus the $75 million of additional capital commitment, for us to stand on our own and get back to healthy, we'd need to either perform through enhanced operations or raise through donations or taxes or some other mechanism $175 million, to sort of equal that 10-year commitment that is coming from quorum. I guarantee you the management fee is going to be a lot less than that.
I know we keep coming back to this quorum piece, but if private equity owns 51% of quorum, could private equity override decisions made by quorum management?
Yeah, I suppose. I mean, I think right now, quorum's performing for them. So I don't know that they have any issues with what they're doing. They have a good margin. They're doing a good job with their hospitals. I don't know that it's an issue. I mean, but that could change. I think to Brian's point, though, they have demonstrated what they said they would do. They have been good partners to this point. And if I can show an example, I can show what they're doing with McKinsey Willamette. I can't guarantee anything much further than that. And to Brian's point earlier, it is going to be it's a much better path than us trying to figure out how we're going to do it on our own. At the end of the day, what's important to me is that our hospital stays open and that you can walk in and receive care from your provider. That's what's important to me. I've heard the term local control. What does that mean, really? You walk in, you still have your neighbor that's there, your provider is still local, the management team's still local, the boards that's there are still local. Yes, there's some money that's leaving our community, but that's leaving it and they're providing us a benefit for it. None of you are going to stop shopping at Safeway. I'm sure some of you bank at US Bank. Those are all large corporations that operate outside of us and with a profit margin. I realize healthcare is different. As to my opening statement earlier, when we were worried about cutting, we said we don't make widgets. We provide care to our community. We can't just cut it. But there is still, to be cliche, with no margin, there's no mission. If we're not able to make money, we can't be here to help anybody. So somebody has to make money. And if we're worried about the management fee that leaves here, I'm not sure why, if what we're getting for that benefit is a great hospital with the services that we need in our community.
I have a question that nobody has asked, but given that the National Congress, the budget did cut the $800 in Medicaid services yesterday. That's maybe not a final number, but anyway. Um, what kind of help can we as citizens give to you? What is helpful to you?
That's a great
We
question.
can do.
I was thinking about that earlier. I was thinking, honestly, as an engaged community as we are that cares about our community and what we have here, reach out to your local leaders, even at the city, the county level. Reach out to your state congressmen, people, and representatives. Reach out to your federal representatives. Let them know, we've got to figure something out. And the louder that voice is, I think the more it's going to help. If we're honest, it is a big ship and it turns really slow. And right now it's pretty unstable, but your voice does count. Use it. Write letters, call, let them know you're concerned about the state of healthcare.
And Brian, do you have any final words you'd like to?
Just a word of thanks for coming out and spending this evening with us. This was a fantastic deck of questions that came from this audience, and we're just we feel honored to have you spend the time and invest in getting educated about healthcare in your local community. If we had a chance to care for you or one of your loved ones, thank you for trusting us. And our mission is to be that dependable source of healthcare that you never need to think about until you need us. And then we're just there for you. Right now, it's taken a little bit of extra concern, and we appreciate this engagement. So thank you.
Thank you. Thank you both very much. And thank you to the audience for showing up. And we appreciate it. And again, if you need to re-register to vote before the 30th of April, you should do it.